This is the audio lecture for Chapter 15, Fetal Assessment During Labor. Fetal Assessment During Labor. Electronic fetal monitoring is a useful tool for visualizing the fetal heart rate patterns on a monitor screen or printed tracing. Electronic fetal monitoring was first used in the 1970s. The anticipated effect of electronic fetal monitoring was a decrease in cerebral palsy. However, the rate has not declined, and we associate that with the increasing rate of premature babies that are surviving now. Electronic fetal monitoring is the primary mode of intrapartum assessment used in the United States. Basis for monitoring: the fetal response. Because labor is a period of physiologic stress for the fetus, frequent monitoring of fetal status is part of the nursing care during labor. The fetal oxygen supply must be maintained during labor to prevent fetal compromise and promote newborn health after birth. The fetal oxygen supply can decrease in a number of ways. Fetal oxygen supply can decrease due to reduction of blood flow through maternal vessels as a result of hypertension and hypotension, reduction of oxygen content in maternal blood as a result of hemorrhage or severe anemia, alterations in fetal circulation with compression of the umbilical cord, and reduction in blood flow to intervillous space in the placenta. Fetal well-being during labor can be assessed by the response of the fetal heart rate to uterine contractions. And like we talked about in class, when we're looking at the fetal tracing, we're looking at how the heart rate reacts to the contraction, specifically the peak of the contraction. So if the heart rate goes down before the peak of the contraction and is back up by the end of the contraction, we call that an early deceleration. And an early deceleration is caused by head compression. Now, if the heart rate starts to go down at the peak of the contraction or after the peak of the contraction, we call that a late deceleration, and late decelerations are caused by uteroplacental insufficiency. Normal uterine activity during labor. In your book, Table 15-1 describes normal uterine activity during labor. Looking at Table 15-1, it describes the frequency. The contraction frequency overall generally ranges from 2 to 5 per 10 minutes during labor, with lower frequencies seen in the first stage of labor and higher frequencies up to 5 contractions in 10 minutes seen during the second stage of labor. So the frequency of contractions is how often the contractions are occurring. Then we have the duration. The contraction duration remains fairly stable throughout the first and second stages, ranging from 45 to 80 seconds and not generally exceeding 90 seconds. So the duration is how long the contractions last. Then the strength. Uterine contractions generally range from peaking at 40 to 7 millimeters of mercury in the first stage of labor to over 80 millimeters of mercury in the second stage. Contractions palpated as mild would likely peak at less than 50 millimeters per mercury if measured internally, whereas contractions palpated as moderate or greater would likely peak at 50 millimeters of mercury or greater if measured internally. So remember what I told you in class: the tip of your nose mild, your chin moderate, and your forehead is a severe contraction. And if we don't have the internal monitor, the intrauterine pressure catheter, we can't tell the exact strength or intensity of the contraction. We can only palpate and kind of guesstimate how strong the contraction is. Now, the resting tone. The average resting tone during labor is 10 millimeters of mercury. If using palpation, should palpate as soft. So the resting tone is the tone of the uterus when it is not contracting. Relaxation time. Relaxation time is commonly 60 seconds or more in the first stage and 45 seconds or more in the second stage. So this is the interval between the contractions. This table also lists Montevideo units. We only can count Montevideo units when we have an internal monitor. So in order to count Montevideo units, you need an intrauterine pressure catheter. And remember, with the intrauterine pressure catheter, you can tell the exact intensity of the contraction. And when we're calculating uh, how intense the contractions are, we use Montevideo units. But don't bog yourself down with that because that's kind of an advanced practice. Fetal well-being during labor is measured by the response of the fetal heart rate to uterine contractions. Reassuring fetal heart rate patterns are: there's a baseline of the fetal heart rate in the normal range of 110 to 160 beats per minute with no periodic changes or decelerations, and a moderate baseline variability. In the preterm infant, baseline fetal heart rate may be a little bit higher than the normal 110 to 160 beats per minute. Fetal compromise. The goals of intrapartum fetal heart rate monitoring are to identify and differentiate the normal or reassuring patterns from the abnormal or non-reassuring patterns, which can indicate fetal compromise. The non-reassuring fetal heart rate pattern are associated with fetal hypoxemia. If uncorrected, this can progress to fetal hypoxia. So some of the non-reassuring fetal heart rate patterns that you'll see and that we're going to talk about is your decelerations, your late decelerations, your variable decelerations, your prolonged variable decelerations, and we're going to talk a little bit about the sinusoidal fetal heart rate pattern. Those are all abnormal or non-reassuring patterns. Intermittent auscultation of the fetal heart rate involves listening to fetal heart sounds at periodic intervals to assess the fetal heart rate. Intermittent auscultation of the fetal heart rate can be performed with a Pinyard stethoscope, a Doppler ultrasound, an ultrasound stethoscope, or a Deeley-Hillis fetoscope. Intermittent auscultation is easy to use, inexpensive, and less invasive than electronic fetal monitoring. It is often more comfortable for the woman and gives her more freedom of movement. Many women, especially my high risk moms, they can't we really don't use intermittent auscultation. We prefer the continuous electronic fetal monitoring, especially if we have a baby who's not dealing well with the contractions. We don't want to listen to that baby's heart rate every 30 minutes or so or every 15 minutes or so. We want to see a continuous fetal monitor pattern so that we can make sure that that baby is not showing any signs of distress. Typically, with your intermittent auscultation, you see it more with your low risk women. A lot of the midwives may use it because their patients may want to get up and ambulate or sit in the tub or sit in the hot shower. But intermittent auscultation is good to use during the first uh, stage of labor, especially in the early latent phase where they're not too uncomfortable, where they can still get up and walk and do things for themselves. This is an illustration of a nurse or a midwife using a Pinard stethoscope. This is figure 15-1 in your textbook. The purpose of electronic fetal monitoring is the ongoing assessment of fetal oxygenation. Fetal heart rate tracings are analyzed for characteristic patterns that suggest fetal hypoxic events and metabolic acidosis during labor. When hypoxia or metabolic acidosis is suspected in labor, interventions to resolve the problem can be implemented in a timely manner before permanent damage or death occurs. The two modes of electronic fetal monitoring are the external fetal monitoring and the internal fetal monitoring. With the external monitor, this is a non-invasive procedure. We use the ultrasound transducer to pick up the baby's heartbeat, and then we use the a tocotransducer to pick up the uterine contractions. We also have what we call internal monitoring. Now, these are invasive, and in order to place internal monitors, the bag of water has to be broken. So, to listen to the baby's heartbeat with internal monitoring, we use the fetal scalp electrode. And to measure the contractions, the internal monitor we use is the intrauterine pressure catheter. This is figure 15-2 in your textbook. A is a ultrasound fetal scope. This is the one I prefer. B is the ultrasound stethoscope. And C is the Dealey Hillis fetoscope. This is figure 15-3 in your book, and this is showing the external non-invasive fetal monitoring with the tocotransducer and ultrasound transducer. So the tocotransducer we place on the fundus of the uterus to measure the contraction, and then the ultrasound transducer we try and place it over the back of the baby because that's where you're going to hear the heartbeat at the best. Then this picture shows the ultrasound transducer is placed below the umbilicus over area where the fetal heart rate is best heard, and the tocotransducer is placed on the fundus of the uterus. So this is what you guys will be doing in the hospital, hooking moms up to the external fetal monitor. This is figure 15-4 in your textbook, and this shows a wireless and beltless device that can be used with existing monitors to obtain fetal heart rate via abdominal electrocardiogram. And B is the electrodes placed on the maternal abdomen monitor ECG from fetal and maternal heart and electromyogram from uterine muscles. So if you are in a place that has this fancy new equipment, this is helpful for moms who may want to ambulate. And then we can still, while they're ambulating, get a tracing of the baby's heartbeat and then see the uterine contractions also. I have not seen this yet in hospitals, but this is very nice setup because more and more you have moms who don't want to be strapped in the bed while they're in labor. They want to get up, they want to move around, and this would be an excellent way to monitor the contractions, monitor the heartbeat, and the mom could still be up walking. She doesn't have to be strapped to the bed. I really like this, and this is something new because, like I said, I have never seen this type of technology, but this is awesome. So this is figure 15-5 in your book, and it shows a woman sitting on a birthing ball with the wireless monitor and a woman ambulating, and they're both wearing the wireless monitor. Baseline fetal heart rate. The baseline fetal heart rate is the average rate during a 10-minute segment that excludes periodic or episodic changes, periods of marked variability, and segments of the baseline that differ by more than 25 beats per minute. There must be at least 2 minutes of interpretable baseline data in a 10-minute segment of tracing to determine the baseline fetal heart rate. After 10 minutes of tracing is observed, the approximate mean rate is rounded to the closest 5 beats per minute interval. For example, if the fetal heart rate varies between 130 and 140 beats per minute over a 10-minute period, the baseline is recorded as 135 beats per minute. The normal range at term is 110 to 160 beats per minute, and in the preterm fetus, the baseline rate is slightly higher. Variability. Variability of the fetal heart rate can be described as irregular waves or fluctuations in the baseline fetal heart rate of 2 cycles per minute or greater. It is a characteristic of the baseline fetal heart rate and does not include accelerations or decelerations of the fetal heart rate. Variability is quantified in beats per minute and is measured from peak to the trough of a single cycle. There are 4 possible categories of variability. They are absent, minimal, moderate, and marked. Depending on other characteristics of the fetal heart rate tracing, absent or minimal variability is classified as either abnormal or indeterminate. It can result from fetal hypoxemia and metabolic acidemia. Other causes of absent or minimal variability include congenital anomalies and pre-existing neurologic injury, CNS depressant medications such as your analgesics or your narcotics, and use of general anesthetics are also other possible causes of minimal variability. Also, the fetus sleep cycle may also be a cause of absent or minimal variability, but you must note that the sleep cycle state usually does not last longer than 30 minutes. Moderate variability is considered normal. Its presence is highly predictive of a normal fetal acid-base balance. Moderate variability indicates that the fetal heart rate regulation is not affected significantly by fetal sleep cycles, tachycardia, prematurity, congenital anomalies, pre-existing neurologic injury, or CNS depressant medications. The significance of marked variability is unclear. A sinusoidal pattern is not included in the definition of fetal heart rate variability. This uncommon pattern classically occurs with severe fetal anemia. Variations of the sinusoidal pattern have been described in association with chorioamnionitis. That's an infection of the chorionic sac and the amnion, the fluid where the baby's at, fetal sepsis, and administration of narcotic analgesics. This picture shows the internal monitor. Here you have the intrauterine pressure catheter, which goes in and it actually measures the contractions. And then this is the fetal scalp electrode that we twist into the baby's scalp. And this is just showing how we just mount it to the thigh so it doesn't move around too much or become dislodged. Okay, this is figure 15-8 in your textbook, and these are pictures of the fetal heart tracing, and it's showing you the difference in the heart rate variability. In A, you see that this is absent variability. The amplitude range is undetectable, and the way that you know that it's absent variability is that it looks like just a straight flat line. You don't see any ups or downs in the baby's heart rate. B is minimal. The amplitude range is detectable, but it's less than 5 beats per minute. And you see how this differs from this one, where this one is kind of a straight flat line. You do have a few changes in the baby's fetal heart rate in this one. So that's minimal and that's absent. Now this is showing moderate, where there is an amplitude range of 6 to 25 beats per minute. This is more what we like to see. We have a baby that looks kind of happy in utero. And then this is D. This is marked variability. You see the amplitude range is greater than 25 beats per minute. And this is figure 15-9. This shows you the sinusoidal fetal heart rate pattern. And we know this is caused by severe fetal anemia. Or usually we see what we call a pseudo-sinusoidal after we've given mom some narcotics. Fetal heart rate patterns. Tachycardia is a baseline fetal heart rate greater than 160 beats per minute for 10 minutes or longer. It can be considered an early sign of fetal hypoxemia, especially when associated with late decelerations and minimal or absent variability. Fetal tachycardia can result from maternal or fetal infection, such as prolonged rupture of membranes with amnionitis, from maternal hyperthyroidism or fetal anemia, or in response to medications such as atropine, hydroxine, terbutaline, or illicit drugs such as cocaine or methamphetamines. In your book, Table 15-3 lists causes and their clinical significance and the nursing interventions to treat tachycardia. So please make sure you look over that table 15-3. Bradycardia is a baseline fetal heart rate less than 110 beats per minute for 10 minutes or longer. True bradycardia occurs rarely and is not specifically related to fetal oxygenation. It must be distinguished from a prolonged deceleration because the cause and management of these two conditions are very different. Bradycardia is often caused by some type of fetal cardiac problem, such as structural defects involving the pacemaker, which is what? The SA node, or the conductive system, or fetal heart failure. Other causes of bradycardia include viral infection, maternal hypoglycemia, and maternal hypothermia. The clinical significance of the bradycardia depends on the underlying cause and accompanying fetal heart rate patterns, including variability and the presence of accelerations or decelerations. And again, Table 15-3 lists causes, clinical significance, and nursing interventions for fetal bradycardia. This is figure 15-10 in your textbook, and then this is showing fetal tachycardia. And if we look here, it looks like the fetal heart rate is going at about 170. And we know 110 to 160 is considered a normal fetal heart rate. Changes in fetal heart rate. Changes in fetal heart rate from the baseline are categorized as periodic or episodic. Periodic changes are those that occur with uterine contractions. Episodic changes are those that are not associated with uterine contractions. These changes include both accelerations and decelerations. Acceleration of the fetal heart rate is defined as a visually apparent, abrupt increase in fetal heart rate above the baseline rate. The peak is at least 15 beats per minute above the baseline, and the acceleration lasts at least 15 seconds or more. So you need a 15 by 15 for it to be considered an acceleration. It's good to know that before 32 weeks of gestation, the definition of an acceleration is a peak of 10 beats per minute or more above the baseline and duration of at least 10 seconds. Acceleration of the fetal heart rate for more than 10 minutes is considered a change in baseline rate, because usually your accelerations don't last for 10 minutes at a time. Your accelerations can be either periodic or episodic. They may occur in association with fetal movement, or they can happen spontaneously. If accelerations do not occur spontaneously, they can be elicited by fetal scalp or vibroacoustic stimulation. And we know that accelerations are considered normal, and it means that I have a happy baby in utero. A deceleration may be benign or abnormal. Fetal heart rate decelerations are categorized as early, late, variable, or prolonged. They are described by their visual relation to the onset and end of a contraction and by their shape. Early decelerations of the fetal heart rate is a visually apparent gradual onset to lowest point greater than 30 seconds decrease in and return to baseline fetal heart rate associated with uterine contractions. We know that the early deceleration is usually caused by head compression, and we consider it a benign type of deceleration. Late decelerations of the fetal heart rate is a visually apparent gradual decrease in and return to baseline fetal heart rate associated with uterine contractions. With your late deceleration, the deceleration begins after the contraction has started, and the lowest point of the deceleration occurs after the peak of the contraction. The deceleration usually does not return to baseline until after the contraction is over. And we know that late decelerations have been attributed to uteroplacental insufficiency. Now this is showing fetal bradycardia, and we say fetal bradycardia is fetal heart rate less than 110, lasting longer than 10 minutes. And right here we have a fetal heart rate that is about 100 beats per minute. Here we have what we call accelerations. Remember, we said the acceleration has to be 15 beats above baseline and last 15 seconds or longer. And when we see accelerations, we know that we have a baby that is doing well in utero. This graph is showing head compression. And remember, when we're talking about decelerations, we need to look at the when the heart rate starts to go down in relationship to the contraction, specifically the peak of the contraction. So here it's going down before the peak, going down before the peak, going down before the peak. And we know that early decelerations are benign, and they're usually caused by head compression. Here's just another, this is actually what you'll see, the fetal heart rate tracing, and then this is showing that, boom, it's going down before the contraction, going down before the contraction, the peak of the contraction. So those are early decelerations. Now, this is your late deceleration. Usually it happens with the peak of the contraction or after the peak of the contraction, and the contraction is over before it comes back up to baseline. And we know that late decelerations are caused by uteroplacental insufficiency. Variable decelerations. Variable decelerations of the fetal heart rate is defined as a visually abrupt and apparent decrease in fetal heart rate below the baseline. The decrease is at least 15 beats per minute or more below the baseline, lasts at least 15 seconds, and returns to baseline in less than 2 minutes from the time of onset. Variable decelerations occur any time during the uterine contraction phase and are caused by compression of the umbilical cord. The appearance of variable deceleration differs from those of early and late decels, which closely approximate the shape of the corresponding contraction. Instead, your variable decelerations have a U, V, or W shape characterized by a rapid descent and ascent to and from the nadir of the deceleration. A prolonged deceleration is a visually apparent decrease in fetal heart rate of at least 15 beats per minute below the baseline and lasting more than 2 minutes but less than 10 minutes. A deceleration lasting more than 10 minutes is considered a baseline change. Prolonged decelerations are caused when the mechanisms responsible for late or variable decelerations last for an extended period. Examples of conditions that can cause an interruption in the fetal oxygen supply long enough to produce a prolonged deceleration include maternal hypotension, uterine tachysystole or rupture. And uterine tachysystole is just when the mom is contracting and she's not getting a break. There's no relaxation phase. Extreme placental insufficiency and prolonged cord compression or prolapse of the cord. Again, this is showing your late decelerations. You want to look and see when the heart rate starts to go down in relationship to the peak of the contraction. You can see it's going down after. It's going down right here with the peak. So those are your late decelerations. Now this is showing what your variable decelerations look like. And you can notice with the variables there's an abrupt, it's a quick up and down. And they're shaped like the letter U, the letter V, or the letter W. And we know that variable decelerations are caused by cord compression. Again, this is just another illustration of what a variable deceleration looks like. So that's like a U or a V, and then I guess this is like a extended W, but that's a variable deceleration. Variable decelerations are caused by cord compression. Care of the woman receiving electronic fetal monitoring in labor begins with the evaluation of the electronic fetal monitor equipment. The nurse must ensure that the monitor is recording the fetal heart rate and uterine activity accurately and that the tracing is interpretable. If you cannot determine what the baby's doing with the external monitor, you then can either ask the physician or the midwife, or in most institutions, nurses can place internal fetal monitoring as long as there is no contraindications, such as if I had a mom who was HIV positive, we would not put internal monitors in that mom. EFM pattern recognition. Nurses must evaluate many factors to determine whether a fetal heart rate pattern is normal or abnormal. They evaluate these factors based on the presence of other obstetric complications, the woman's progress in labor, and the use of analgesia or anesthesia. They also must consider the estimated time interval until birth. Therefore, interventions are based on clinical judgment of a complex integrated process. Now, this is what we call a prolonged deceleration. So if we're seeing the baseline, let's say the baseline is 125, and here we start to go down and we get down to about 60, and it stays down, and it doesn't look like it gets back to baseline until about here. So if you're counting, that's a 1, 2, 3, 4, 5, 6, 7-minute prolonged deceleration. Categorizing fetal heart rate tracings. There is a three-tier system of categorizing fetal heart rate tracings. Category 1 fetal heart rate tracings are normal and strongly predictive of normal fetal acid-base status at the time of observation. These tracings may be followed in a routine manner and do not require any specific action. Your Category 2 fetal heart rate tracings are indeterminate. This category includes all tracings that do not meet Category 1 or Category 3 criteria. Category 2 tracings require continued observation and evaluation. Your Category 3 fetal heart rate tracings are abnormal. Immediate evaluation and prompt intervention are required when these patterns are identified. In your textbook on page 396, please look over the blue box. It's titled Legal Tip, Fetal Monitoring Standards, and it just gives you a brief look at what the perinatal nurse is responsible for. So the perinatal nurse is responsible for interpreting the fetal monitor tracings. They're responsible for initiating interventions based on the patterns, documenting those interventions and those patterns, and notifying the physician or the midwife in a timely manner. Now, if a perinatal nurse sees an abnormal pattern on the fetal heart rate tracing, there are some basic corrective measures that she can do to try and either fix the irregular pattern or change the pattern. So, some basic corrective measures include providing supplemental oxygen, instituting maternal position changes, and increasing intravenous fluid administration. We do these interventions to improve uterine and intervillous space, blood flow, and increase maternal oxygenation and cardiac outputs. So, typically, if we start seeing abnormal fetal heart rate patterns such as late decelerations, variable decelerations, we will put oxygen on the mom, and typically we use the mask and you put it at 10 liters per minute. We can position change the mom, turn her side to side, sometimes hands and knees, whatever it takes to correct the fetal heart rate tracing. We can also increase her IV fluids if we're thinking that the baby's heart rate is reacting to maternal hypotension, usually what we see after an epidural is placed. Additional methods of assessment and intervention. A major shortcoming of electronic fetal monitoring is its high rate of false positive results. Even the most abnormal patterns are poorly predictive of neonatal morbidity. Therefore, other methods of assessment have been developed to evaluate fetal status. Fetal scalp stimulation, vibroacoustic stimulation, and umbilical cord acid base determination are frequently performed assessments. Fetal scalp blood sampling is another available assessment technique. Amnioinfusion and tocolytic therapy are interventions often used in an attempt to improve abnormal fetal heart rate patterns. Now, with the amnioinfusion, the way we do this, and I remember talking about this in class, the mom has to have an intrauterine pressure catheter, and what we do with the use of the IUPC, we instill fluid back into the uterus in hopes of reversing an abnormal pattern. Usually, when we're doing an amnioinfusion, we're doing it for variable decelerations. And tocolytic therapy, tocolysis means to stop the contractions. So if we have a mom who's maybe contracting too much and we want to give the baby a little rest period, we can use a tocolytic. Typically, we'll use some IV or sub-Q terbutaline, and this allows the uterus to rest a minute and gives the baby time to kind of recover. Additional methods of assessment and intervention. Part of the nurse's role includes acting as a partner with the woman to achieve a high quality birthing experience. In addition to teaching and supporting the woman and her family with understanding of the labor and birth process, breathing techniques, use of equipment, and pain management techniques, the nurse can help with two factors that have an effect on fetal status: positioning and pushing. The nurse should encourage the woman to not lie in a supine position, but usually side to side or in a semi Fowler's position. We can talk about the different pain management techniques with the patient. Usually, I like to explain to them about the epidural, what the epidural does, the position that they would have to assume, the amount of fluids, the laps, and all of that stuff. Also, I tell them about the intravenous IV pain medications. And, I tell them, it's not going to take away all of the pain, but it'll help you relax while you're not contracting. But I have to tell them we have to time it very carefully because I don't want to give it and the mom delivers within maybe 30 minutes, 45 minutes, because it's going to cause respiratory depression in the fetus if we give it close to delivery. Documentation is also very important for the perinatal nurse. In most places, it is all now computerized charting. Everything is documented the tracing is documented on, the mom's assessment, all of that stuff is done via the computer. Also, documentation is different from hospital to hospital. Those hospitals that don't use electronic fetal monitoring or don't have computerized systems, um, they still will print out a physical fetal heart rate tracing strip, and they either will document everything on the monitor tracing, or they will document on the labor and delivery flow sheet. It kind of depends. Back in the old days, before we had the computerized system, everything we did to the mom, to the baby, we would chart it on our fetal heart rate tracing and also on our labor flow sheet. So it was almost like a double documentation thing. But with the computerized charting, everything goes right on the computer, and it puts it on the tracing, or it puts it where it needs to go. So it's a big help. This is figure 15-20 in your textbook. It's a way that providers can access near real-time fetal heart rate tracings and review patient data using their mobile phones. And like I said in class, they also have it where they can log in from a remote location, such as their office and their home, and they can actually see what's going on with the patient, document on the tracing, order things that the patient may need. So it's very convenient, and it also takes a lot of the legality part off of the nurses, because the doctor can actually monitor their own tracings from wherever. And this is figure 15-21 in your textbook, and it just shows the nurse explaining the TOCO and the ultrasound to the patient. Question: fetal tachycardia is most common through A. maternal fever, B. umbilical cord prolapse, C. regional anesthesia, D. magnesium sulfate administration. The answer is A. maternal fever. This concludes the audio lecture for Chapter 15, Fetal Assessment During Labor. If you have any questions, please make sure you text me, email me, call me, or see me in class. Thank you.